This video will describe the vision for clinic hubs and the ways of applying integrated care pathways within smart recovery. Some of the details are still blurry, but in the coming months work will be done with the clinicians that will actually be working in the hubs to make the picture clearer. Now, we all know how it feels when a working day just flows, when one task moves seamlessly into another and everything just seems to get done with fairly minimal effort. Unfortunately, working in the NHS, things don't always move. Nobody likes waiting. It's wasted time. And this has only been a few seconds. And when systems break down and things don't flow, then time and effort is completely wasted. And it's only when a system works, and works well, that we get the outcome that we're looking for. As a result, the clinic hubs are going to be quite heavily managed so that the system works and that things just flow. First, we'll start by looking at the clinic hubs from the patient's perspective. Meet Toby. Now, he's usually happy-go-lucky, enjoying life by the seaside in Devon, but the last few weeks have been tough. He stopped going to the places that he loves best. Despite his cheery social facade, which mostly comes from the fact that I don't have any sad-looking Lego blocks, he has become depressed, trust me. He's been staying in a lot more, and he's also had some symptoms that might have been psychotic. He's become a little paranoid, and realising that self-medication with alcohol wasn't really helping, he went to see his GP. His GP did his best. First of all, he told him to stop drinking, and then he gave him a leaflet that he found somewhere in a cupboard. But this didn't really help. His GP followed the evidence that he remembered from medical school. First he gave yellow tablets, and when yellow tablets didn't work, he gave red ones. After this, he didn't really know what to do, so he referred Toby to DPT. His GP didn't know quite which team he wanted to refer to, but the single point of access made that decision simple. The new single point of access took the referral. The administrator made sure the GP had given us all of the information on the standard template. Toby's GP was good and it was complete, so it was then passed on to a senior nurse for triage. The nurse looked at the information and decided that it wasn't anything urgent, so the crisis team was stood down. It looked like Toby could come in for a routine assessment at one of 3 of the big clinic hubs. The administrator booked Toby straight into one of the clinicians' diaries. In the new system, clinicians will only be using an electronic diary and will be handing the control of it across to administrators. So the administrator called him back on the phone to arrange for him to come into one of our clinic hubs. He had a text reminder on the day before. We knew exactly when he was due, so we reserved him a space in the designated patient parking. This meant that he could be on time and the clinic would flow. Toby then came to the reception, where Joan, the receptionist, was waiting to greet him. This was our chance to check that all of Toby's personal information was correct, that we had the right phone number and address, and he was then taken straight to the treating room without having to wait in a waiting room. The waiting rooms have been designed out of the clinic. After all, it's not very respectful to ask a patient to hurry up and to be on time, only for us to leave them waiting to see us. Toby is instead taken straight to the room, handed a tablet so that he can complete some information on his own clinical record. We know that in clinical medicine, a lot of questions can be answered with a fairly simple yes or no, and Toby sets to work to complete them. He knows that Joan's there to help him if he gets stuck with the IT. On the tablet, Toby watches a video about storing clinical information and completes his consent there and then. He answers some yes-no questions about his family history and some of his current physical symptoms. He then completes 2 validated measures. The first, given that he's a general adult patient, is a very brief screen for personality disorder, the SAPAS, and this asks yes-no questions, like, are you normally a worrier? He also completes the EQ5D, which allows us to calculate a quality-adjusted life year, which is the same measure used in physical healthcare to rate quality. Next up is Jackie, the medicines management technician. Like most people working in pharmacy, she's fond of a green pen. She goes through Toby's tablets with him and talks to him about how the yellow ones made him feel sick and the red ones aren't really working. She makes sure that his medicines reconciliation is complete and then has a discussion about his thoughts on medications generally. It's also a chance to check his blood pressure, height and weight. Next up is Bella, a Band 6 occupational therapist who will be Toby's main assessor. She takes all of the information that Toby has already put into the computer and looks at Jackie's notes about medicines and clarifies anything that she needs to. She then completes her assessment, and some of this is standardised, partly because it makes it quicker and easier to put the information onto the system, but also because there are certain basic standards that we should follow in mental health. For example, no one should leave an assessment without us giving a comment on whether we think they're depressed or not. Towards the end of the assessment, Bella realises that something will need to be done with Toby's medicines. There is a consultant on hand so that she can discuss Toby's case, and together they decide on a plan of action. They agree that the consultant does not really need to see Toby, and medicine's advice is all that is necessary. By doing all of that work beforehand, it's freed up enough time to make a good job of patient-centred care planning. Bella has enough time to do this well, and Toby is given a copy of his care plans before he leaves. Bella explains that he has moderate severity depression, and this now means that he will be on the depression care pathway. A care pathway simply spells out the options that are on offer from our service, and this means that for Toby he has 3 main choices at this point. 1. The biological part of the pathway. This is usually medication, and will mean that Toby has access to either a consultant or a non-medical prescriber. By making sure his medications are the right medicines at the right doses, the hope is that he will get better sooner. 2. The psychological pathway. NICE guidelines make it very clear that patients with depression should be offered psychological therapies. This is a chance to have a discussion with Toby about CBT. It was also a chance to dispel his myths about what psychology actually involved. 3. The psychosocial pathway. And this is predominantly the work that a recovery navigator or a care coordinator might do. At the end of the assessment, they agree that Toby will see Barry, whose clinical acumen is fortunately much better than his dodgy dress sense. All of these appointments will be booked before Toby leaves, and it means that he has a clear idea of who he will see and when. Joan, the receptionist, comes back to check that Toby has all the patient information he was meant to receive, all of the leaflets and that all of the arrangements are in place, and Toby then goes home. Meet Bella, the same OT that saw Toby. She also likes living the good life in Devon. She started the day at 8 AM, as the clinics run from 8 AM to 8 PM, and she was on the earlier shift. The day started with a huddle, where the whole assessing team, including medics, psychologists and nurses, came together to have a brief look through the referrals. This was a chance to get some pointers and thoughts before the first patient appeared in clinic. A new role in this system is that of flow manager. The flow manager's job is to make sure that the clinic runs according to time, but with enough flexibility to do what is needed. The flow manager's job will be to conduct the whole orchestra of the clinic, with the right things coming in at the right times, and the right work being done at the right pace. This will involve telling clinicians where to go and when. They will need to make sure that the IT works properly. They will also be an important line of defence, fielding calls and allowing clinicians to focus on the work in hand on the days that they are in clinic. Bella knew that Toby had turned up and was now ready to be seen, having completed his information and been seen by the medicines management technician. Before seeing him, she had the completed documents by all the other professionals, and this meant that she knew his medications were accurate and that he had a family history of both depression and suicide. She knew he didn't have any current physical health problems, and his score on the SAPAS meant that a personality disorder was unlikely. By completing an assessment where some of it was standardised, this allowed Bella to put the information on the system more quickly and to generate part of the letter. This cut down the amount of time she spent typing on the computer, and actually allowed her one more slot to see patients. This is a way of increasing the efficiency of the assessment service. Because the clinic was so heavily managed, Bella was able to complete her work and get home on time, which allowed her to continue enjoying the good life down in Devon.